Hi everybody and welcome to our SNP Learning Presentation 3. We will be talking about yeast, alcohol and cardiovascular lipids today. Can we just see a show of hands to make sure that everyone can actually hear us? Thanks Becky, thanks Scott, great, and Jennifer, thanks very much. Okay, good. Well, we've only got Sterling and I today. Cynthia's had a bit of technical difficulties, so she won't be joining us. So it'll be Sterling and I to run through everything with you today. Now, as you will have seen from the slides, there is a lot to get through. So we're going to not spend too much time, if any, on the diagrams. That'll be for your home reference. But we've got a lot of insight that we can share with you with Sterling today on the factor, particularly the factor genes and the APOE. So without further ado, I think we'll get straight into Sterling's yeast alcohol metabolism. That's our first section today. So Sterling, over to you. She's muted. Yeah, okay, she's right now. Okay, thanks, Sterling.
Give me a minute, and I am going to start with the ADH1B, okay? ADH1B is alcohol dehydrogenase 1B. This enzyme is encoded by ADH1B, and it is a member of the alcohol dehydrogenase family. Members of this enzyme family metabolize a wide variety of substrates, including ethanol, retinol, other aliphatic alcohols, hydroxysteroids, and lipid peroxidation products. ADH1B is related to alcohol sensitivity, which may be due to increased formation of acetaldehyde by persons with the atypical ADH1B. ADH1B may be related to alcohol allergies. Genetic differences in these enzymes may help to explain why some ethnic groups have higher or lower rates of alcohol-related problems. For example, one version of the ADH enzyme called ADH1B2 is common in people of Chinese, Japanese, and Korean descent, but rare in people of European and African descent. Another version of the ADH enzyme called ADH1B3 occurs in 15 to 25% of African Americans. These enzymes protect against alcoholism by metabolizing alcohol to acetaldehyde very efficiently, leading to elevated acetaldehyde levels that make drinking unpleasant. Okay. Now, the ALDHs, alcohol dehydrogenase family, and it's related to mitochondria. The enzyme encoded by ALDH2 belongs to the aldehyde dehydrogenase family of enzymes that catalyzes the chemical transformation of acetaldehyde to acetic acid. Aldehyde dehydrogenase is the second enzyme of the major oxidative pathway of alcohol metabolism. Additionally, ALDH2 functions as a protector against oxidative stress. Most Europeans have two major isozymes, while approximately 50% of Northeast Asians have one normal copy of the ALDH2 gene and one variant copy that encodes an inactive mitochondrial isozyme. Also in native Japanese, this variant ALDH2 gene encodes lysine instead of glutamic acid at AA location 487, and therefore encodes a product protein that is completely inactive in metabolizing acetaldehyde to acetic acid. Accordingly, Japanese individuals, heterozygous or homozygous for the abnormal gene, metabolize ethanol to acetaldehyde normally, but metabolize acetaldehyde poorly, and are thereby susceptible to certain adverse effects of alcoholic beverages. These effects include transient accumulation of acetaldehyde in blood tissues, facial flushing, urticarial systemic dermatitis, and alcohol-induced respiratory reactions such as rhinitis and asthma. ALDH3A2 is aldehyde dehydrogenase 3 family member A2 dehydrogenase. It is also called fatty aldehyde. Fatty aldehyde dehydrogenase isosomes play a major role in the detoxification of aldehydes generated by alcohol metabolism and lipid peroxidation. In other words, they function to remove toxic aldehydes. Fatty aldehyde dehydrogenase does this via catalyzing the oxidation of long-chain aliphatic aldehydes into fatty acids and acts on a variety of both saturated and unsaturated aliphatic aldehydes between 6 to 24 carbons in length, as well as the hydrophytyl and 20 carbon branch chain aldehyde. In addition to its role in alcohol detoxification, fatty aldehyde dehydrogenase plays an important role in the metabolism of catecholamines, specifically dopamine and epinephrine. Therefore, in addition to COMT, MAOA, and MAOB, and associated DRD receptor SNPs, LDH3A2 SNPs, and their impact on catecholamine aldehydes should be considered when addressing catecholamine breakdown issues. Carolyn?
Okay, you're finished with that section. Okay. Now, some people are having problems trying to get some of the slides, so I have asked my girls to email them to everybody, and hopefully she'll get that message as soon as possible, because I can't, because my screen is being used as the main screen. So we'll continue, and hopefully she'll get them to you very shortly. Okay, so we're going to talk first of all about the ADH1B SNPs. And this protein encodes by the protein that encodes this gene is a member of the alcohol dehydrogenase family. And the members of this enzyme family metabolize a wide variety of different substrates, particularly ethanol, retinol, and other aliphatic alcohols, hydroxysteroids, and lipid peroxidation products. This is quite a good, and it's probably the only pathway I'll go through with you today, because it's really good one to show this metabolism of the different alcohols. And basically the first step is that the ADH, or alcohol dehydrogenase enzymes, oxidize the beverage alcohol. Primarily they use the ADH1B and the ADH1C. And then it's the aldehyde dehydrogenase, the ALDH, which we'll talk about next, that oxidizes the acetaldehyde to acetate. And predominantly that is done by the ALDH2, number 1 and number 2. And this aldehyde is oxidized to acetate, and the thickness of the arrows that you can see indicates the rate of aldehyde oxidation in people carrying 2 or homozygous alleles of the ALDH2 number 1. And cancer-inducing substances, so any of the carcinogens, can actually be generated during this pathway of alcohol metabolism. And we know that acetaldehyde is a very potent, and some of the research is telling us, carcinogen. And so if we can't get rid of them, particularly with the effect of the CYP2E1, then we're going to be forming these toxic acetaldehydes and reactive oxygen species. So it's not a good scenario. So the ADH1B SNPs, the reason that many of them are associated with cancer, as I've said, is that there's quite a bit of evidence that shows that acetaldehyde is a carcinogen, and that's according to the International Agency for Research on Cancer. So what they've found is that acetaldehyde inhalation in rats and hamsters actually resulted in cancer of the nasal mucosa and the larynx. And when you've got this long-term administration of acetaldehyde, then it changes. You end up with an excessive cell growth And they've seen that in drinking water, where they've had an effect on the mucosa cells of the upper respiratory or the digestive tract. And it's similar to what we see in people with chronic alcohol ingestion, because the acetaldehyde is going to produce inflammation, and we get this transformation of the cells lining the windpipe, the trachea, and so it interferes with the normal reproduction of cells. And so you can imagine that we're going to get enhanced cell injury of the whole digestive tract and excessive cell growth. So I guess the key things we've got to be looking at with these ADH1B SNPs is when there's excessive alcohol production, that's a really big deal. A really interesting fact was that these particularly any of the aldehyde genes they're very high in Asian populations, and so you've got to be looking at people that are consuming a lot of alcohol, and the clinical trials don't say it's got to be an excessive amount if you're homozygous to this. So it's really got to be a low alcohol consumption that we're recommending. And we've also got to be wary of any potential carcinogenic foods. So obviously, as we know, our environment is key. If you have these particular SNPs that have the potential to promote carcinogenic action, then we've got to look at our environment. We've got to look at our diet. We've got to look at our lifestyle, our stress component, and in our environment where we live. So that's important. And when you're looking at these alcohol metabolism genes, don't look in isolation. We've got to look at the ADH, the ALDH2, CYP2E1, because they're key when we're talking about the breakdown of alcohol, and obviously all our oxidative stress pathways like superoxide dismutase and the glutathione genes that we talked about on Wednesday, and obviously catalase as well. So the ALDH2 SNPs, they're aldehyde dehydrogenase 2, and they belong to the phase 1 oxidizing enzyme responsible for the detoxification of all these biogenic and xenogenic aldehydes. It's the second major oxidative pathway of alcohol metabolism. So really important, as you saw from that diagram. These really are key. Caucasians have 2 major isozymes. However, what's really interesting is 50% of Asians have this mutation, and that would explain why we see generally that Asian populations do not cope with their alcohol particularly well. That equates to 500 million people in the world that have this particular SNP. And so if there is excessive alcohol use, we've got to be really careful. So for those practitioners in Australia, this is a really big one to be looking out for in your Asian patients, to ensure that their alcohol pathway is not being overloaded by the ingestion of alcohol. This is quite a good graph to have a look at, the breakdown of alcohol and these aldehydes. And the most relevant SNP in the ALDH2 is the ALDH2 number 2, which is the RSID 671, because they do have that lower enzymatic activity. And this drawing shows the aldehyde-induced mitochondrial damage, and it shows how the ALDH2 reduces this aldehydic toxicity. On the left, you can see ischemia and reperfusion and other oxidative stress in the heart. And what this will do, obviously, is increase our reactive oxygen production. That then triggers lipid peroxidation and the accumulation of these really reactive aldehydes. And you'll see one of them is written there as 4-HNE. So we've got to be, even food additives and things like that can increase this cellular aldehyde load, for want of a better word. And the aldehydes really induce inactivation of a number of our really important electron transport chain proteasomes in the mitochondria, and so it will lead to mitochondrial impairment and increased oxidative stress. And that's why we see cancer associated with so many different forms of, alcohol associated with so many different forms of cancer. This is really just to show the role of ALDH in preventing numerous pathologies. And they do use this clinically, particularly with patients that have problems with alcohol addictions. So if we look at the particular SNPs, you can see there that with the 1694167, they've shown association between alcohol consumption and gastric cancer. And the two key ones that seem to be working in unison for that is the ADH1C, which is what we discussed before, which is that first part of our breakdown of alcohol, and the ALDH2, which is this 1694167. And individuals that carried the alleles for both of them were twice as likely to develop gastric cancer. So that's interesting, and as I said, we've really got to be looking at these in combination. The 671, that's the one that we say ALDH2 number 2, and you'll see a lot of research about this particular gene. It is a down regulation, and this is the particular variant that is found in roughly 50% of East Asians, so Chinese, Japanese, Korean, and Taiwanese, and it has that lower enzymatic activity. And so one of the signs and symptoms of this particular gene expressing is facial flushing, headaches, nausea, dizziness, and even cardiac palpitations after consumption of alcohol beverages. So interesting that you can look out for that. Folate, you can see there's a reference with regard to folate consumption inversely associated with the risk of the pharyngeal cancer with the alcohol drinking. And obviously that makes sense because these genes will all work together predominantly because we know that proliferation of cells is stopped by the correct amounts of folate, and cancer is reduced in good amounts of folate. So the key things we've got to be looking here is reduction of alcohol consumption. We highly recommend for those that are homozygous for both the ADH and the other, I would say, really limit alcohol. Healthy diet obviously is key. Our environment is what helps these genes express. We need to protect the liver, we need to protect the pancreas, and be aware of some of those signs and symptoms of the ALDH2 number 2 deficiency. Interestingly, that our isoflavones will inhibit this further. So how many of our Asian patients are having much of the isoflavones? That's a huge percentage. So we've really got to be careful that we're not inhibiting this in these people that have this particular SNP that is inhibited hugely. So that's a really interesting fact, because how many Asian populations really live on their isoflavones? And in the pharmaceutical market, they actually do have a drug class known as ALDA1, which actually activate this pathway. But I couldn't really find anything that gives us an indication that this is there's anything natural that we can do to speed up this pathway. Okay, so we're now going to break all our cardiovascular and lipids down into subcategories. We're going to look at them through cardiovascular disease, HDL, LDL, Alzheimer's, other neurological, cancer and tumour, and type 2 diabetes. So the cardiovascular pathway, I'll leave that. I mean, that really just shows the importance of our HDL as a central role in the reverse cholesterol transport pathway. And you can see there our APOA1 genes and some of the other genes. So it gives you a bit of an idea what we're talking about. So the key SNPs in in some of these pathways are these. They're not necessarily all being discussed today, but some of the others we will discuss in other sessions. Now, Sterling's going to take you through some of these specific genes, firstly starting with the ADAM and APOE. Thanks, Sterling.
You're welcome. Okay, ADAM12, Adam 12. That was a show at one time in America. Adam 12 is also called Adam metallopeptidase domain 12. It pretty interesting here. This gene encodes a member of a family of proteins that are structurally related to snake venom, disintegrants, and has been implicated in a variety of biological processes involving cell-cell and cell matrix interactions, including fertilization, muscle development, and neurogenesis. Expression of this gene has been used as a maternal serum marker for prenatal development. Adam12 and metalloprotease that binds insulin growth factor binding protein 3 appears to be an effective early Down syndrome marker. Decreased levels of ADAM12 may be detected in cases of trisomy 21 as early as 8 to 10 weeks gestation. It also has been implicated in the development of pathology in various cancers, hypertension, liver, fibrogenesis, and asthma. In asthma, ADAM12 is upregulated in lung epithelium in response to tumor necrosis factor alpha. Okay, and some little disease relevance here on ADAM12. Says liver cancers with ADAM9 and ADAM12 expression is associated with tumor aggressiveness and progression. It also shows that there is, with ADAM9 and ADAM12, that there's an increase in hepatocellular carcinomas and liver cancers from colonic carcinomas. The disintegrin metal proteinase ADAM9 and ADAM12 and ADAM15 are upregulated in gastric cancer. ADAM12 is a member of a family of disintegrin-containing metalloproteases that have been implicated in a variety of diseases, including Alzheimer's disease, arthritis, and cancer. Okay. Now, APOE, this one I'm going to talk a little bit about, and then I'll talk more about it after we're finished here, talking about the gene itself. APOE mediates the binding, internalization, and catabolism of lipoprotein particles. It can serve as a ligand for the LDL receptor and for the specific APOE receptor of hepatic tissues. Okay, hold on 1 second. All right, hyperlipoproteinemia, better known as HLPP3, is a disease caused by certain APOE mutations. The vast majority of the patients are homozygous for APOE2 alleles. More severe cases of HLPP3 have also been observed in individuals heterozygous for rare APOE variants. The influence of APOE on lipid levels is often suggested to have a major implications for the risk of coronary artery disease. Individuals carrying the common APOE4 variant are at higher risk of coronary artery disease. All right. Now, the disorder is characterized by accumulation of intermediate density lipoprotein particles rich in cholesterol. The clinical features include xanthomas, yellowish lipid deposits, in the palmar crease are less specific on tendons and on elbows. The disorder rarely manifests before the third decade in men, and in women it is usually expressed only after menopause. The APOE4 allele is genetically associated with the common late onset familial and sporadic forms of Alzheimer's disease. Risk for AD increased from 20 to 90% in men at the age onset, decreased from 84 to 68 years with an increasing number of APOE4 alleles. Okay, now here comes the good stuff here. APOE is essential for the normal catabolism of triglyceride-rich. Hold on one second. I got lost there. APOE is a class of apolipoprotein found in the chylomorphin, an intermediate density lipoprotein that is essential for the normal catabolism of triglyceride-rich lipoprotein constituents. In peripheral tissues, APOE is primarily produced by the liver and macrophages and mediates cholesterol metabolism in an isoform-dependent manner. In the central nervous system, APOE is mainly produced and transports cholesterol to neurons via APOE receptors, which are members of the low-density lipoprotein receptor gene family. This protein is involved in Alzheimer's disease and cardiovascular disease. Epsilon 2, which is RS7412 on our variant report, has an allele frequency of approximately 7%. This variant of the apoprotein binds poorly to cell surface receptors, while epsilon 3 and epsilon 4 bind well. E2, epsilon 2, is associated with both increased and decreased risk for atherosclerosis. Individuals with epsilon 2-2 combinations may clear dietary fat slowly and be at greater risk for early vascular disease, and the genetic disorder type 3, hyperlipoproteinemia. Epsilon 3, that's RS429358 on the variant report, has an allele frequency of approximately 79%. It is considered the neutral APOE gene. Epsilon 4 has an allele frequency of approximately 14%. It has been implicated in atherosclerosis, Alzheimer's disease, impaired cognitive function, reduced hippocampal volume, HIV, faster disease progression and multiple sclerosis, unfavorable outcome after traumatic brain injury, ischemic cerebrovascular disease, sleep apnea, accelerated telomere shortening, and reduced neurite outgrowth. A notable advantage of the E4 allele is a positive association with higher levels of vitamin D, which may help explain its prevalence despite its seeming complicity in various diseases or disorders. APOE transports lipoproteins, fat-soluble vitamins, and cholesterol into the lymph system and then into the blood. It is synthesized principally in the liver, but it has also been found in other tissues such as the brain, kidneys, and spleen. In the nervous system, non-neuronal cell types, most notably astroglia and microglia, are the primary producers of APOE. While neurons preferentially express the receptors for APOE, there are 7 currently identified mammalian receptors for APOE, which belong to the evolutionary conserved LDLR family. APOE was initially recognized for its importance in lipoprotein metabolism and cardiovascular disease. Defects in APOE result in familial hyperlipoproteinemia, in which increased plasma cholesterol and triglycerides or the consequence of impaired clearance of chylomicron, VLDL, and LDL remnants. More recently, it has been studied for its role in several biological processes not directly related to lipoprotein transport, including Alzheimer's disease. Compared to the vast majority of the population carrying the more common E3 and E4 isoforms of APOE, the few who have an APOE2 allele enjoy reduced risk of late-onset Alzheimer's. A new study sheds light on the underpinnings of this protection, analyzing cognitively normal subjects enrolled in the Alzheimer's disease neuroimaging initiative. Researchers report that the epsilon 2 carriers not only have biomarker signatures indicating less Alzheimer's disease pathology, but also lower hippocampal atrophy rates. Relative to epsilon 3 homozygotes, cognitive decline did not differ between the two groups over the study's 24-month time frame. However, the work provides evidence that the protective effect of the APOE2 genetic polymorphism is detectable in vivo before there is evidence of cognitive impairment. Only 5% of the population carries the E2 allele, those who are less likely to develop late-onset Alzheimer's disease and seem to have slower rates of cognitive decline. The study found that relative to E3 homozygotes, E2 carriers had baselines, CSF profiles reflecting little or no Alzheimer's disease pathology. The rate of neurodegeneration as marked by hippocampal atrophy was lower in E2 positive people. Another intriguing observation from the 90-plus study of non-agenarians seems to turn the tables on the apparent link between E2 isoform and reduced AD pathology. Non-demented epsilon 2 characters had higher amyloid load than did the E3 individuals. Okay, BCHE. That stands for butyrylcholine esterase. All right, BCHE mutant alleles at the BCHE locus are responsible for succinylmethylminium sensitivity. Homozygous persons sustain prolonged apnea after administration of the muscle relaxant succinylmethylmonium in connection with surgical anesthesia. The activity of pseudocholine esterase in the serum is low and its substrate behavior is atypical in the absence of the relaxant. The homozygote is at no known disadvantage. Diseases associated with BCHE include pseudocholine esterase deficiency and chloroform drugs toxicity. So choline esterases inactivate the neurotransmitter acetylcholine by catalyzing its hydrolysis to choline and acetic acid. BCHE deficiency is a metabolic disorder characterized by the prolonged apnea after the use of certain anesthetic drugs, such as local anesthetics. The duration of the prolonged apnea varies significantly depending on the extent of the enzyme deficiency. Okay, now I'm going to talk about CYP4V2. This one's pretty interesting. Let me get to it. Hold on. Give me a second here. All right, CYP4V2. This one's pretty interesting because if you see, for instance, you do a fatty acid profile on somebody and you see their laurates highly elevated, and people really push coconut oil as it's healthy for many people. But there's some people they might have trouble breaking it down. So I'll go on and talk about CYP4V2. It's also called cytochrome P450 4V2. CYP4V2 omega hydroxylase that oxidizes medium-chain saturated fatty acids and polyunsaturated omega-3 fatty acids, and which plays a role in fatty acid and steroid metabolism in the eye. So you hear that fatty acid steroid metabolism in the eye. If you ever have a client, a patient that has like little white kind of elevated bumps in their eye, they could be having this problem here with CYP4V2 in breaking down certain fatty acids. It catalyzes the omega hydroxylation of medium-chain saturated fatty acids such as laurate, myristate, and palmitate in an NADPH-dependent pathway. The substrate specificity, tongue-tied again, is higher for myristate, laurate, and palmitate. It acts as a polyunsaturated omega-3 fatty acid hydroxylase by mediating oxidation of docosahexaenoate and 22-hydroxy-docosahexaenate. Also, it produces 21-hydroxy-docosahexaenate. Also, it converts icosapentaenate to 20-hydroxy-icosapentaenate. Let me see if there's any. There's the big disease is, of course, with the eye here, and it's called BCD. It stands for bidecrystalline corneoretinal dystrophy, so BCD. The disease is caused by mutations affecting CYP4V2. It's an autosomal recessive ocular disease characterized by retinal degeneration and marginal corneal dystrophy. Typical features include multiple glistening intraretinal crystals scattered over the funda, a characteristic degeneration of the retina, and sclerosis of the choroidal vessels, ultimately resulting in progressive night blindness and constriction of the visual field. Most patients have similar crystals at the corneoscleral limbus. Patients develop decreased vision, nyctalopia, and paracentral scotomata between the second and fourth decade of life. Later, they develop peripheral visual field loss and marked visual impairment, usually progressing to legal blindness by the fifth or sixth decade of life. Let's see, I've got a little bit more. I found this one interesting. They said psychiatry-related information on CYP4V2. Those who met the BCD criteria had significantly higher PTSD symptom scores than those who did not. That was pretty interesting. But I think I'm finished with that section now, Carolyn.
Okay, thanks, Sterling. So we're going to go through these in a little bit more detail. So ADAM12 SNPs, as Sterling said, it's structurally related to snake venom disintegrins. And these have been implicated in a variety of biological processing, which involves our cell-to-cell and cell-to-matrix interactions. So fertilization, muscle development, neurogenesis. And interestingly, expression of this gene has been used as a maternal serum marker for prenatal development. That's certainly something I didn't know prior to researching that particular gene. We're not going to go through the pathway. I'll leave that, but you can just see that key pathway. And what the research is telling us, there is an interesting article that showed that it was related to osteoarthritis, and because it's an important transmembrane protein. APOE, really, I guess the key thing here is that we know that it provides instructions for making our apolipoprotein E, and this protein combines with fats in the body and it forms our lipoproteins. So if we remember back from our biochemistry, they're responsible for packaging up our cholesterol and other fats and carrying them through the bloodstream. So as we know that if we want to maintain normal levels of cholesterol and prevent things like heart attack and cardiovascular disease and stroke, then we've got to ensure that these lipoproteins are at sufficient numbers. There are 3 slightly different allele versions, as Sterling said, our E2, E3 and E4. The most common allele is the E3. There's links with Alzheimer's disease, particularly with the E4 version, and they're more likely to develop late onset Alzheimer's. And there's certainly the clinical studies are telling us that it's associated with early memory loss. So it's certainly one to consider if you're seeing that E4 as a homozygous SNP. And the reason is that because the allele is associated with a number of protein clumps, our amyloid plaques in the brain, then it's obviously going to affect the tissues of the brain. And there's our APOE pathway, and you can study that in more detail. And really, if we look at the 429358, that's our 4 version, you can see some of the links there with high triglycerides, late onset Alzheimer's. The 7412 is our APOE2, and as Sterling said, there's an increased risk of hyperlipoproteinuria. And this, for people that are homozygous, you're more likely to see elevated blood cholesterol, elevated triglycerides, and our elevated very low density lipoproteins. And so it's important also to look at this in relationship to our folate metabolism, because remember we said on Wednesday to effectively ensure that the liver is doing what it needs to do, you've got to have significant amounts of our SAMe. So lots of things, and as Cynthia said in our very important last presentation, we'll be looking at some of these things and how to tie it together. The 429358, as we said, associated more with dementia and interestingly sleep apnea in children was the 769455. And bone density too. They're not sure why, but it seems to be due to the effect of saturated fatty acids, which they've hypothesized is more detrimental to the bone matrix. So that was interesting too. BCHE SNPs, it provides instructions for making pseudocholinesterase enzyme, and this is, and it's particularly butyryl cholinesterase. Problem with doing these biochemistry classes, Sterling, as you know, there's so many tongue-tying words that we've got to get around, but we'll get there. So this is produced by the liver and circulates in the blood, and it is involved in the breakdown of certain drugs. So including muscle relaxants, so choline esters that are used during general anesthesia, and these drugs are used to relax muscles. They're used for movement, including muscles involved in breathing, and often employed in emergencies when a breathing tube must be inserted. This pseudocholinesterase also helps protect the body because it breaks down certain toxic substances before they reach the nerves. And these might be pesticides, poisons that attack the nerves, and specific natural toxins, particularly, which is interesting, solanine that we find in green potato skin. We've always been told that green potato skin is toxic, but it's obviously not that we would want to eat it, but interesting, it's that particular solanine that this BCHE gene will help us break down. There's roughly about 50 mutations in this gene, and it seems that the biggest effect for people with this gene is that they're going to have an increased sensitivity to choline esters and other certain drugs that we've already mentioned. There's our BCHE pathway, and in terms of the key research, it is associated. Interesting, the butyrylcholinesterase that this gene produces metabolizes cocaine. And so obviously you would expect that the BCHE gene will affect cocaine metabolism. And so we see this particular SNP, the 1803274, as a risk factor for crack cocaine use. So that was an interesting side. The CYP4V2, it provides, as Sterling said, it's a member of the P450 family of enzymes, but it's involved in the formation and breakdown of various molecules and chemicals within the cell. And it's particularly involved in fatty acid oxidation, in which our fats are broken down, converted into energy, but the enzyme, they don't really know its specific function, but obviously if you're going to have fatty acid oxidation issues, then it is related to venous thrombosis. And here's our 4V pathway. The research is really just saying that, obviously it's involved, it's connected with deep vein thrombosis and venous thromboembolism, and particularly when it's combined with the GP6 RSID 1613662. Now, Sterling has got some key things she just wants to talk to us about with regards to the APOE gene. So I'm just going to pass you back on to Sterling, who will run through a couple of extra interesting bits. You there, Sterling?
Yeah, I just wanted to let people know. Yeah, can you all hear me?
Yep.
Can you hear me?
Yes, we can.
Okay. I wanted to let you all know where you could go and get some interesting information. I got to meet Dr. Stephen Gundry. His name is spelled Stephen. It's good to write down his name and look him up. Just Google him, Stephen Gundry, and APOE behind it. He has over 400 peer-reviewed research articles out there on APOE and other cardiolipid issues. Very brilliant man. He's also invented the device that keeps your heart beating when they have to do heart transplants and stuff. Pretty interesting doctor, very brilliant. And he started getting into the genetic and nutrition part of this when he had a couple of patients clear up some cardiovascular disease with nutrition and supplements. And he saw it, so he believed it. And that's when he got into really studying hard about APOE. So he's really a good person to go to. What I've learned from him is that a lot of the epsilon 4s have what they call grain brain. That it's really good to get the omega fatty acid profiles on people, especially with APOE 4s that are chronically ill. And their diet is probably loaded with white things and grain. I've learned that. Their 6s, when they're really having problems, their 6s will be much higher than their 3s. So somebody with APOE4, for instance, wouldn't want to be taking something like sunflower lecithin and driving that omega-6 fatty acid up. If they needed a type of lecithin, it would be better for them to go with an omega-3 fatty acid. That's always good to know. Also, there is an interesting man. He was doing through Kentucky University. His name is Dr. Boyd Haley, and that's B as in boy, O-Y, D as in dog, Haley. Haley. You can watch him on YouTube because he's been interviewed extensively, and just go on YouTube and put in Boyd Haley and APOE or Alzheimer's. And what he had noticed when he did the study, the cadavers, he got every one of them almost every one of them that had Alzheimer's. What he found their connection was mercury amalgam fillings and high levels of things like mercury and lead in the brain. And tying in Dr. Stephen Gundry with him, learning when those omega-3s and 6s are off, that might be some type of link to why these people are not removing metals out of their brain. Not only did Dr. Boyd see that, Dr. Boyd Haley see that these people had high levels of mercury and lead in their brain, but they also, their brain was much smaller. And we have pulled up research too that just being born with an APOE4 mutation, your brain is a little different than somebody who, for instance, is a 3-3. It's sort of rare to see 4-4s, but they are there. I used to meet with a lot of people and go over their SNPs, and maybe 1 out of 200 people I would see as a 4-4, and before I'd even talk to them, I would dread it, because people that are chronically ill and you see 4-4s, they don't really hold a lot of memory there. You have to tell them over and over again. Now, not everybody with an APOE4/4 is going to be like that, but chronically ill people with APOE4/4 seem to, you want to work on that immediately, and work with them, see if they have mercury amalgams in there. I've also spoken with, I forget if it was Dr. Gundry or another doctor that specializes in APOE4, and they said that when you remove mercury amalgam fillings on somebody who's a 4, you want to make sure that their omega-3/6 ratios are good to go. You also want to make sure you've got methylation working, because you can really, when you remove, even though you're going as careful and using a biodentist, removing the mercury amalgam, really, really have a lot of problems there if you don't make sure that's working properly. So that was interesting in itself. Also, you know, these people, they have to really stay away from metals. Metals are the enemy with them. It can cause Alzheimer's to hit faster on the 4s. But I wanted to share all that information with you. I hope you got a little something out of it. Carolyn, I guess I can start the other section.
Yes, so do you want to now take us through all the coagulation, F2 through 5? Yep.
Okay, I sure will. Let me get to my little spot here. All right. Now, F2 is also known as factor 2 prothrombin. It's a thrombin which cleaves bonds after arginine and lysine converts fibrinogen to fibrin and activates factors 5, 7, 8, and 13, and in complex with thrombomodulin protein C. It functions in blood homeostasis, inflammation, and wound healing. Now, all these, before I get to the other factors, all of them they're connected like dominoes. So when you have something go wrong in one spot, it's going to cascade. Everything's going to fall over on here. And there's certain genes that are more critical that I can talk to you about later. Now, F3, that's tissue factor, factor 3. It initiates blood coagulation by forming a complex with circulated factor 7 and factor 7A. The 7A, the TF7A complex activates factors 9, or 10 by specific limited proteolysis. TF also plays a role in normal homeostasis by initiating the cell surface assembly and propagation of the coagulation protease cascade. Okay. Factor 5, coagulation factor 5, central regulator of homeostasis. It serves as a critical cofactor for the prothrombinase activity of factor 10A that results in the activation of prothrombin to thrombin. And I'll talk more about factor 5 in a minute after we go through all these factors. I'll let Carolyn talk about hers, and then I can come back and share what I know about it. All right, coagulation factor 7, F7. It initiates the extrinsic pathway of blood coagulation, serine protease, that circulates in the blood in a zymogen form. Factor 7 is converted to factor 7A by factor 10A. Factor 7A, factor 9A are thrombin by minor proteolysis in the presence of tissue factor and calcium ions. Factor 7A then converts factor 10 to factor 10A by limited proteolysis. Factor 7A will also convert factor 9 to a factor 9A in the presence of tissue factor and calcium. F8 protein is also called factor 10. Okay, factor 10 is, again, it's just in that cascade of things. And what a lot of doctors will do if they see somebody who's hypercoagulable, they clot a lot, they can actually not even see if they have the gene. They can test to see and what percentage they're working, if it's working too much or if it's working too little. Now, F11 coagulation factor 11. Factor 11 triggers the middle phase of the intrinsic pathway of blood coagulation by activating factor 9. Okay, I believe I'm finished with all the factor ones there.
Okay, great. Thank you. Okay, so we'll just quickly run through these individually. F2, it's a key in making prothrombin, which we call coagulation factor 2. And these coagulation factors, as we know, as Sterling just said, are really crucial for normal blood clotting. So our prothrombin is primarily made by liver cells, and it circulates in the bloodstream in an inactive form until there's some sort of injury that damages either our blood vessels. And in response to injury, it's prothrombin that's converted to the active form of thrombin. And it's thrombin that then converts to fibrinogen into fibrin, which is how we make our clots, or we allow the blood to clot. And it's thought that thrombin is involved in cell growth and division. So that's important. And some mutations will drastically reduce the activity of prothrombin, and so will lead to severe bleeding episodes. Other mutations allow for just a small amount of prothrombin activity, and that will just cause a mild bleeding episode. But none of the mutations really will eliminate prothrombin functions. And it's this mutation that really causes most cases of prothrombin thrombophilia changes. And in my patients, if I see any of these homozygous SNPs with a patient, I will always check the coagulation factors in the blood. F3, it obviously encodes for coagulation factor 3, and it's a cell surface glycoprotein. And this really enables cells to initiate the blood coagulation cascade. And there are pretty well 3 different domains for this factor: extracellular, transmembrane, and cytoplasmic. The F5 is obviously encodes for a protein called coagulation factor 5, again made primarily by cells in the liver, and it circulates in the bloodstream in an inactive form until the coagulation system is activated by damage or blood vessel injury. And when it's activated, it interacts with coagulation factor 10, and it forms this complex which is important in the prothrombin to convert to its active thrombin. And factor 7 is, the only other thing I want to say about factor 5 is that there's about 100 mutations in the F5 that have found to cause rare bleeding called factor 5 deficiency. And I think that's pretty well all. The factor 5 is the specific name in the factor 5 gene. And as we know, anyone who deals with pregnancy, this factor 5 laden mutation can cause thrombophilia, and it definitely puts people at higher risk of developing abnormal blood clots. The factor 7 encodes factor 7, and that's a vitamin K dependent factor that, as we know, vitamin K is essential for our hemostasis. Factor 9, it is made again in the liver, circulates until there's an injury, and key mutations in this gene will cause hemophilia, and specifically a hemophilia called hemophilia B. The reason is that they lead to a production of an abnormal version of coagulation factor 9 and reduce the amount of that protein. And so with the altered or missing protein, people can't effectively participate in this blood clotting process. And so as a result, the blood clots can't form properly in response to injury. There's several rare mutations in this that actually cause an increased sensitivity to warfarin. And warfarin will reduce the amount of factor 9 to very low levels in these individuals. So that will actually prevent the blood from clotting normally and can lead to really severe bleeding issues. Factor 10, it's again made in the liver. There's about 130 mutations that have been found to cause a rare bleeding disorder called factor 10 deficiency. And it's common, the sort of symptoms that you would see in that would be nosebleeds, easy bruising, bleeding under the skin, perhaps bleeding of the gums, blood in the urine, and prolonged or excessive bleeding following some sort of operation or trauma or something like that. Factor 11, it is important, obviously, as part of this. It contributes to the factor 8A or factor 12, and it is involved in the middle phase of the blood coagulation pathway. Key health conditions related to this are factor 11 deficiency. It's a hemorrhagic disease. It will be characterized by reduced levels of factor 11, and that can result in bleeding, particularly after trauma or surgery. And in some patients, it could even be spontaneous bleeding in women that present with menorrhagia or heavy periods. So interesting to consider that we probably should be looking, apart from estrogen metabolism, we should definitely be looking at these coagulation SNPs in relation to people who are having particularly heavy periods when they're not related to estrogen dominant conditions like fibroids and cysts and things like that. This is just a pathway to show you that when the endothelium is damaged, the normally isolated underlying collagen is exposed to circulating platelets. And it's probably good to show you how all of these factors work together. And as far as the research goes, Sterling did cover a lot of this, but they're related predominantly to thrombophilia, venous thrombosis, thromboembolism, and excessive bleeding post-operatively. So they're the key things that you want to be looking out for. I guess as far as the key things we should be thinking of, obviously that for those people who have the bleeding disorders, we've got to make sure that they're not doing stupid sports that might be contributing to injury or damage. Our diet is really important. We've got to look at vitamin K levels, ensure that their environment is good, and obviously avoid things that smoking and things that affect oxidative stress. So before we move on to the other cardiovascular diseases, Sterling's just going to have a quick word about the F2 and give you a bit more insight into those. So Sterling, over to you.
Okay. Yeah, I wanted to make you all aware of something. The F2 G20210A, that particular SNP, we do have it under blood clotting. The reason I bring that one up, if you see someone heterozygous there, they should keep an eye for life on what's going on with their coagulation. Now, the other one is factor V Leiden, okay? Just one heterozygous SNP there as well. They need to keep an eye for life on that. I'll give you an example. You will probably never see somebody homozygous for factor II prothrombin G20210A because they usually die very early if they make it out the womb. Factor V Leiden, again, extremely rare. They're lucky if they make it to 18. I have met, I also do a lot of work with pulmonary embolism awareness. I've been working with them for about 7 years now, and we have seen people that have factor V, one heterozygous factor V Leiden, and then the factor II prothrombin 20210A, and they usually die pretty young too if they don't keep an eye on their coagulation. You'll never, very rarely see somebody homozygous for those mutations, but you will see a compound heterozygous there every now and then, maybe 1 out of 2,000 people who clot. That's how rare it would be. But when you do, they're walking blood clots. One thing you would always want to, some of the key factors that they would always want to keep an eye on with FBL, factor V Leiden, or with G20210A, factor II, would be Lyme disease, platelet counts, protein C, and fibrinogen. Okay? Keeping an eye on this. Another thing, what a lot of allopathic hematologists will tell people to do is avoid vitamin K. There are new studies out there now that actually show people who avoid vitamin K can't keep their PT-INR, the prothrombin time, in check. If they stay consistent with the small amount of vitamin K rich foods that they are eating, they control much better their prothrombin time, their platelet, their hypercoagulation gets under control more. Some people go naturally with stuff. Now, if somebody is vitamin K deficient and anytime they do take vitamin K and they get a blood clot, vitamin K2 passes that. It bypasses K1, and it will not affect their prothrombin time like K1 does. As you know, we need vitamin K for the gut as well, for the healing process. So it's really important to know that K2 will do the job. Now, where you would want to watch out, though, is if somebody was actively G6PD deficient. Sometimes those people will destroy their red blood cells and oxidatively damage their reduced glutathione if they do have actual hemolytic anemia from G6PD. Vitamin K doesn't get along with those people too well. Also, I think I'm right about done there, but the line, the platelets, the protein C, the fibrinogen, again, heterozygous for G2021A factor 2, keep an eye on what's going on with their vascular system in their blood for life. Factor 5 Leiden as well. Okay, I guess I can start talking about the other section here, huh?
Yes, and let's just say at this point, if anyone does have questions, please start sending them through, and we might even answer them in each section as we go. But yes, Sterling, please, let's go on to the next section.
Okay. GP6, that's platelet glycoprotein 6. It's a collagen receptor involved in collagen-induced platelet adhesion and activation. It plays a key role in platelet procoagulant activity and subsequent thrombin and fibrin formation. This procoagulant function may contribute to arterial and venous thrombosis formation. The signaling pathway involves the FcR gamma chain and the SRC kinase. The adaptor protein LAT and leads to the activation of phospholipase C gamma 2. All right, let me get to my next gene here. All right. Now, the next gene is the HRG, heme transporter HRG1, also known as SLC48A1. All SLC genes are transporters, okay? And it's a heme transporter that regulates intracellular heme availability through the endosomal or lysosomal compartment. It is highly expressed in the brain, kidney, heart, and skeletal muscle. It is moderately expressed in the liver, lung, placenta, and small intestine. All right. Now, okay, ITGB3, that's integrin beta 3. ITGB3, integrin alpha beta 3, is a receptor for cytotactin, fibronectin, laminin, matrix metalloproteinase 2, osteopontin, osteomodulin, prothrombin, thrombospondin, vitronectin, and von Willebrand factor. Von Willebrand is, your easy bleeders, low platelets. Integrin alpha 2B beta 3 is a receptor for fibronectin, fibrinogen, plasmogen, prothrombin, thrombospondin, and vitronectin. It also is found in a wide array of ligands. Right. There was actually a HIV in a case through PubMed. There was a case of HIV-1 infection, and the interaction with the extracellular viral TAT protein seems to enhance angiogenesis in Kaposi sarcoma lesions. So I guess if you have somebody with HIV and Kaposi sarcoma, they might be having trouble with their ITGB3. All right, now KNG1, this is kininogen 1. Kininogens are inhibitors of thiol proteases. Kininogen plays an important role in blood coagulation by helping to position optimally pre-kallikrein and factor 11 next to factor 12. Kininogen inhibits the thrombin and plasmin-induced aggregation of thrombocytes. The active peptide bradykinin that is released from kininogen shows a variety of physiological effects. It's influenced in smooth muscle contraction, and it is an induction of hypotension. It is decreased in blood glucose level. It is a mediator of inflammation and causes an increase in vascular permeability. It's a stimulation of nociceptors, and the release of other mediators of inflammation. It is a cardioprotective effect, and the kininogen inhibits the aggregation of thrombocytes. Kininogen is in contrast to the LMW kininogen is in contrast to the HMW kininogen, but not involved in blood clotting. Okay. Now, one disease that they found that is related to it, it's called high molecular weight kininogen deficiency. And it's caused by this particular gene. And it is an autosomal recessive coagulation defect. Patients with HWNK deficiency do not have a hemorrhagic tendency, but they exhibit abnormal surface-mediated activation of fibrin. Now, LRP6, that's low-density lipoprotein receptor-related protein 6. Now, LRP6 is a complex that triggers beta-catenin signaling through inducing aggregation of receptor ligand complexes to ribosome-sized signalsomes. Cell surface co-receptor of the WNT beta-catenin signaling, which plays a pivotal role in bone formation. The WNT-induced LRP6 co-receptor complex recruits polymers to the plasma membrane, which in turn recruit the AXIM1 GSK3B complex to the cell surface, promoting the formation of signalsomes and inhibiting AXIN1 and GSK3 mediated phosphorylation and destruction of beta-catenin required for posterior patterning of the epiblast during gastrulation. And I don't know if there's any diseases related to this one here. There is. It's coronary artery disease, of course. That's the section we have it in, and it's autosomal dominant. They call it ADCAD2. And it's a common heart disease characterized by reduced or absent blood flow in one or more of the arteries that encircle and supply the heart. It is most important complication is acute myocardial infarction. Okay, there is some other information on it. Again, with the cardiovascular up in here, I'm going to see if there's anything really important. It just keeps on repeating cardiovascular in the blood flow, the poor blood flow that's missing in the arteries that supply the heart. All right. Now the next one is nociceptin receptor, OPROL1, and that is a G protein coupled opioid receptor that functions as a receptor for the endogenous neuropeptide nociceptin. It is ligand binding and causes a conformation change that triggers signaling via guanine and nucleotide binding proteins. Those are your G proteins. And it modulates the activity of downstream effectors. The signaling via the G proteins mediates inhibition of adenylate cyclase activity and calcium channel activity. So this one's really important with calcium channeling. The restrins modulate signaling via G proteins and mediate the activation of alternative signaling pathways that lead to the activation of MAP kinase. It plays a role in modulating nociception and the perception of pain. It plays a role in the regulation of locomotor activity by the neuropeptide nociceptin, which is an opioid receptor. All right, let me see. All right, now we're at MTHFD1L, methylene tetrahydrofolate dehydrogenase 1, like NADP-dependent MTHFD1L. Okay, well, MTHFD1L, again, very, very important, plays a role in folate. Also, I know Carolyn, about a year ago, introduced me to, we were trying to figure out why some people were having issues, again, with folinic acid and having a toxic buildup, and she had found a major connection to MTHFS and MTHFD1L. Those combinations can become folinic acid toxic. I thought I would add that in after I read about it here. Now, the 1-carbon substituted forms of tetrahydrofolate are involved in the de novo synthesis of purines and thymodylate and support cellular methylation reactions through the regeneration of methionine from homocysteine. MTHFD1L is an enzyme involved in THF synthesis in mitochondria. All right. Now, there's again, this is to do with not only cardiovascular but also methylation, and it's found mainly in the human. It says it's found in human placenta, high up in there. Also, it plays a huge role with MTHFS, MTHFR, DHFR. It's identified in many children with autism having issues there too. So it gets kind of worrisome, because I know a lot of people have been pushing that, take folinic acid to some children with cerebral folate deficiency and autism, and that could be a little scary there. So that's, again, where you always want to see somebody looking at their variant report and saying, hey, okay, we see somebody homozygous for MTHFD1L and MTHFS. Folinic acid is a no. We have to go somewhere else with these children. Let's get to the next. Let's see here. Okay, the SERPINC1. Okay, this one also is known as the serpin peptidase inhibitor. In psychiatry-related information, it says that they examined the presence of the AT3 in the pathological lesions of Alzheimer's disease. So this is the SERPINC1 is found at high levels in lesions of people with Alzheimer's disease. It says it regulates the proteolytic activity of thrombin in serum, and it may regulate the activity of serine proteases at and near the cell surface. Okay, it's a prominent inhibitor of thrombin in serum. The PN here links thrombin probably via an ester bond. And it's found, there was another study, an injury of the lungs in mice that had greatly reduced presence of the SERPINC1 in them. So they had lung damage with lesser presence, with a deficiency of it. That was pretty interesting to find that information on it. In the biological part of it, the the fibrinolysis is strongly activated, and the SERP is utilized in sepsis. Let's see, what we have also, it is possible that heparin could interact with endothelium and bind to the SERP to maintain a state of thromboresistance. That's pretty interesting because we know that the SERP has to do with cardiovascular and stuff, and if somebody, I guess, is affected here at SERP, INC, that they could have a negative reaction to heparin. That's really important to know. Also, there are some associations of SERP INC1 with chemical compounds. The levels of fibrinogen and factor VIII and von Willebrand antigen and all activities of the AT3 were significantly decreased in groups with physical training while values were unchanged. That was one of the studies in it. So it's interesting to know about the heparin though, because this is a cardiovascular SNP. So if somebody would have a reaction to heparin, you might want to look into SERPIM1C, see if there's something going on there. And our next one is TF, that gene. It's serotransferrin. And this one's pretty interesting because, again, it's to do with ferritin. Transferrins are iron-binding transport proteins which can bind to ferritin 3 ions in association with the binding of an anion, usually a bicarbonate. It is responsible for the transport of iron from sites of absorption and heme degradation to those of storage and utilization. Serum transferrin may also have a further role in stimulating cell proliferation. Okay. Now the next one here is TFAM, transcription factor A, and it's mitochondrial. It binds to the mitochondrial light strand promoter and functions in mitochondrial transcription regulation. It is required for accurate and efficient promoter recognition by the mitochondrial RNA polymerase. It promotes transcription initiation from the HSP1 and the light strand promoter by binding immediately upstream of transcriptional start sites. It is able to unwind DNA. It bends the mitochondrial light strand promoter DNA into a U-turn shape via the HMG boxes. It is required for maintenance of normal levels of mitochondrial DNA. It may play a role in organizing and compacting mitochondrial DNA. All right. THBD is also called thrombomodulin. Thrombomodulin is a specific endothelial cell receptor that forms a one-to-one stoichiometric complex with thrombin. This complex is responsible for the conversion of protein C to the activated protein C. Once evolved protein C scissions the activated cofactors of the coagulation mechanism for factor 5A and factor 8A, and thereby reduces the amount of thrombin generated. It's calcium ion binding, so that's really important to know. And it has to do with blood coagulation and female pregnancy too, so it's related a lot to miscarriage. Now the disease that is related to it is thrombophilia due to thrombomodulin defect, and they named the disease for short THPH12. And the role of the thrombomodulin in thrombosis is controversial. It is likely that genetic or environmental risk factors, in addition to THBD, variation are involved in the pathogenesis of venous thrombosis. It is also a hemostatic disorder characterized by a tendency to thrombosis. Also, there is another disease related to it that's pretty interesting, hemolytic uremic syndrome, atypical 6, and the science community has named it AHUS6 for short. And it is a typical form of hemolytic uremic syndrome. It is a complex genetic disease characterized by microangiopathic hemolytic anemia, thrombocytopenia, renal failure, and absence of episodes of enterocolitis and diarrhea. In contrast to typical hemolytic uremic syndrome, atypical forms have a poorer prognosis with higher death rates and frequent progression to end-stage renal disease. And I think THBD is my last one. I think you're up, Carolyn.
Yep. Okay. Thanks, Sterling. All right. So we're going to go through these pretty quickly because we're running out of time as usual. So GP6 we've already established is a glycoprotein, and it plays a critical role in our collagen-induced platelet aggregation and thrombus formation. It's, I guess the key thing that we need to consider here is it may contribute to arterial and venous thrombus formation, and typical effects of this gene may be bleeding disorders or what we call a platelet type 11 issue, mild to moderate bleeding, and certainly nothing to, from a bleeding perspective, it seems to be that the SNPs are quite mild. There's our pathway, and if we look at the HRG, as Sterling said, it's a histidine-rich glycoprotein, and it's located in plasma and platelets. And they're not really sure exactly how it works, but it's known to bind heme, dyes, and divalent metal ions. And interestingly, the protein also has a peptide that has antimicrobial activity against Candida albicans, E. coli, Escherichia's, and Physalis. So interesting that two of the proteins' effects is that it also inhibits fibrinolysis, and as Sterling said, we will get issues with thrombophilia. And there's our pathway. ITGB3, it is involved in integrins, and they're our cell surface proteins, and they help with this cell adhesion and our cell surface signaling. It's also, as Sterling said, connected with von Willebrand factor, and it brings about platelet to platelet interaction. So it will lead to rapid platelet aggregation. So obviously if we're going to get effects with this, we are going to have effects with our bleeding cascade. KNG, this is interesting because it actually generates two different proteins, what we call high molecular weight kininogen and low molecular weight kininogen. And these are essential, again, for our blood coagulation. And it's the people with the HMWK, the high molecular weight kininogen, that don't seem to have the hemorrhagic tendency, but they do have abnormal activation of fibrinolysis. Our LRP6, I don't think I have too much more to add than what Sterling said, other than when we see SNPs here, it's common in heart disease because we're getting a reduced or absent blood flow in one of or more of the arteries. So we've got to consider that this will definitely lead to cardiovascular risk. Our MTHFD1L, We're going to talk about this in some of the other classes, so we probably won't go into detail, but it is really key because it is involved in our synthesis of tetrahydrofolate. And we know from our planners that tetrahydrofolate really needs to go up and down the folate chain so that you can recycle your tetrahydrofolate. And so it will have an overall effect on our folate levels. And particularly, as Sterling was saying, there's a relationship between this folinic SHMT. And when I look at those SNPs, the MTHFD1L, the MTHFS, SHMT, I'm considering that folinic acid is way too high. And so overall methyl status is low. Now, I've tested this in hundreds of my preconception patients when I'm looking to see their overall methyl status, and really I don't even need to check anymore because the pattern you will always see is elevated folinic and way too low methylfolate. And so these are the people that absolutely you should not be giving folinic acid to. And, a lot of our prenatal supplements now that are moving over, they've got high doses of folinic, and they're definitely not right for some patients. So keep that in mind. The SERPINC1, it really provides instructions for making our antithrombin. And that's it's what we call a serine protease inhibitor, or a SERPIN. And these really control several types of chemical reactions because they block the activity of certain proteins. And we know that antithrombin is found in the bloodstream, and it's really important in controlling our blood clotting. So it makes sense that these types of genes are involved with the antithrombin deficiency. And I think there's our pathway planner. And if we look at our transferrin, interesting and importantly, these transport iron from the intestine, the reticuloendothelial system, and our liver cells to all proliferating cells in the body. So absolutely key. We need to consider this in conjunction with our other iron SNPs that we mentioned before, the HFE. TFAM, it's a key mitochondrial transcription factor, and very importantly, it's involved in mitochondrial DNA repair and replication because, as Sterling said, it helps unwind our DNA so that we can transcribe it. So if we can't do that efficiently, we're going to have issues with correct DNA or even just DNA replication. THBD. So this endothelial specific type 1 membrane receptor, again, it binds thrombin, and so it's going to help with the activation of protein C. And we know that that's key in our clotting cascade. So mutations of this gene are a cause of thromboembolic disease. And I think that's all I really want to say about that one. From the research perspective, the key genes, I think, for venous thrombosis in this section is definitely the GP6, and specifically the 1613662, and when it's combined with that CYP4V2 that we discussed before. As Sterling said, there are various SNPs in this GP6 that we've got to look at that may be elevated in recurrent miscarriage. And the typical SNPs that we look at in the GP6, which aren't necessarily all on the variant report, but they will be later on, is the 1671153, 1654410, 1654419, and combined with the 1613662. So if we're seeing that, and we're seeing MTHFD1, we're seeing issues with our 677T MTHFR gene, we've really got to be looking at how we can improve the preconception chances of someone with these multiple genes, because we definitely associate MTHFR gene with multiple recurrent miscarriage, but we've got to be looking further afield in our more difficult patients. MTHFD1, again, you can read through that. I don't think I'll go through those in any more detail than we already have. So I guess the things we need to be considering is obviously diet, lifestyle, environment. They're all key. But when you've got people that have issues with these coagulation factors, we need to be doing the coagulation studies. We need to be considering vitamin K levels. We need to be considering our omega-3s. We need to be considering the omega-3 to omega-6 ratio. We need a healthy diet. We need to be avoiding things that will, and look at all the cardiovascular risk factors, so body weight, blood pressure, homocysteine levels, diet, lifestyle. All these things are going to be really important in bringing this together now that you know a lot more about these particular genes. So Sterling, we're going to run into now the cholesterol, and let's just quickly go through our HDL genes.
Okay. All right. The CETP is the cholesterol ester transfer protein. It is involved in the transfer of neutral lipids, including cholesterol ester and triglyceride, among lipoprotein particles. It allows the net movement of cholesterol ester from high-density lipoproteins, HDL, to triglyceride-rich, very low-density lipoproteins, VLDL. And the equimolar transport of triglyceride from VLDL to HDL. It regulates the reverse cholesterol transport by which excess cholesterol is removed from peripheral tissues and returned to the liver for elimination. So I guess you can go ahead and talk about it now, if you want, Carolyn.
Yep, thanks, Sterling. Okay, so CETP, as Sterling said, it's our cholesterol ester transfer protein, and I guess the key thing is it's involved in this reversing cholesterol transport, so that we're removing excess cholesterol from the system. I think the other thing to keep in mind here is that it allows this net movement of cholesterol ester from our high-density lipoproteins to the HDL, to triglyceride, and our VLDLs. So really important in the transportation of these important esters. LDL, if you look at some of the research, as we saw from that chart in the very beginning, it's important for, we don't want too low an HDL, and this really has a role in decreasing our HDLs too much. The CETP gene also, because it is affecting our cholesterol, it's obviously going to be affecting our hormones, but it will have an effect on brain function, and particularly with Alzheimer's disease. And it's the CETP1405V that really is the most significant one, because it does have an effect with a faster rate. It have a faster rather than a slower rate of decline in cognition. So it is associated with an increased risk of Alzheimer's disease. The important things, again, as we just said, I won't repeat this, but diet, lifestyle, environment, omega-3s, making sure we've got good amounts of fish and things like that in our diet that obviously aren't full of mercury. Sterling, let's just go into our LDLs now, LDLR and PCSK9.
Okay. Um, all right. The LDLR is low density lipoprotein receptor. It binds LDL, the major cholesterol carrying lipoprotein of plasma, and transports it into the cells by endocytosis. In order to be internalized, the receptor Ligand complexes must first cluster into clathrin-coated pits. It acts as a receptor for hepatitis C virus and hepatocytes, but not through a direct interaction with viral proteins. It also acts as a receptor for vesicular stomatitis virus, and again, in case of HIV infection, may function as a receptor for extracellular TAT in neurons, mediating in internalization in uninfected cells. Now, the next one is the PCSK9. That's the proprotein convertase subtilisin caxin type 9, PCSK9. It's a crucial player in the regulation of plasma cholesterol homeostasis. It binds to low-density lipid receptor family members. Low-density lipoprotein receptor, LDLR, very low-density lipoprotein receptor, VLDLR, and apolipoprotein E receptor, LRP1 and APOE-R, and apolipoprotein receptor 2, and promotes their degradation into intracellular acidic compartments. It also acts via a non-proteolytic mechanism to enhance the degradation of the hepatic LDLR through a clathrin-mediated pathway. It may prevent the recycling of LDLR from endosomes to the cell surface or to direct to lysosomes for degradation. It also can induce ubiquination of LDLR, leading to its subsequent degradation. It inhibits intracellular degradation of ApoB via the autophagosome lysosome pathway in an LDLR-independent manner. It is involved in the disposal of non-acetylated intermediates of the BACE1 in the early secretory pathway. It inhibits epithelial Na channel-mediated absorption by reducing ENAC surface expression, primarily by increasing its proteasomal degradation. It also regulates neuronal apoptosis via modulation of LRP8, APOER2 levels and related anti-apoptic signaling pathways. Okay, Carolyn.
Okay, so LDL are SNPs, easy for us to remember that, and as Sterling said, they're integral in because they are primarily carrying our cholesterol in the blood. And as you may know, they sit on the outer surface of many of the cells, and they pick up these LDL proteins that are circulating in the bloodstream and bring them into the cell. And once they're in the cell, then they're broken down to release cholesterol. And we then know that cholesterol is used by the cells, stored and removed from the body. So when these lipoprotein receptors drop off their cargo, they've got rid of their cholesterol, they're then recycled back to the cell surface. So it makes sense that if this is a down regulation and we don't have enough of these LDL receptors circulating around the body, then we're going to have a dysregulation with our cholesterol. And we know that mutations in this particular gene are going to contribute to what doctors would call familial hypercholesterolemia. And there's about 1,000 mutations in this particular gene alone. So we've got to be considering then that if transport if the mutations are disrupting the receptor's ability to move all these LDLs from the blood, then we would expect to see high blood cholesterol levels in these particular patients. And then we have to use strategies to help with the breakdown of cholesterol, and perhaps look at diet and lifestyle as well. The PCSK9, that again is helping our regulation of cholesterol, but it seems to control the number of our low density lipoprotein receptors. So these two are obviously going to be working in unison, because the receptors will bind to LDLs, and basically the studies are showing us with this particular one is it helps control blood cholesterol levels because it's going to break down the LDL receptors before they reach the cell surface. And so again, mutations in this gene, like the previous one, they're going to be involved with high cholesterol levels. And I think if you've got an overactive PCSK9, then you're going to reduce the number of these receptors. And if you've got fewer receptors, then you will have, again, high blood cholesterol levels. The LDL research really, Sterling said that, but it's interesting to note that 60% of Caucasians have this particular SNP. So that's interesting, isn't it? And so it's associated with roughly a 10% increase in total and LDL cholesterol, particularly in our premenopausal women. Again, diet lifestyle is going to be really important, increasing our high fiber foods to help reduce some of get rid of some of that cholesterol, a more lower cholesterol, better fat type diet. Now, I think, Sterling, for the purpose of getting through this presentation, I think perhaps we'll just run through the key ones in this particular, because everybody's obviously got the presentation slides and can read. So why don't we just get you to talk about the key ones that you think are affecting people in this particular, in the Alzheimer's. And we've spoken pretty much about some of these in the past anyway, because we're affecting our cardiovascular function, we're affecting the clotting, we're affecting the breakdown of cholesterol. So it makes sense that a lot of these will be affected.
Yeah, I guess I can go through a few of them and just give you a kind of a short of it. How about the ABCA7? That one's ATP binding. Is that subfamily A member 7? And it plays a role in phagocytosis and macrophages and apoptotic cells, and binds APOA1 and may function as an apolipoprotein-mediated phospholipid efflux from cells. It may also mediate cholesterol efflux, and it may also regulate cellular ceramide homeostasis during keratinocytes differentiation. Now, the amyloid beta A4 precursor protein, binding family B member 2, APBB2, that one modulates the internalization of beta amyloid precursor protein. And then we have amyloid beta A4 protein, APP, and that one functions as a cell surface receptor and performs physiological functions on the surface of neurons relevant to neurite growth, neuronal adhesion, and axonogenesis. It is also involved in the cell mobility and transcription regulation through protein-protein interactions, and it can promote transcription and activation through binding to APBB1, KAT5, and inhibits Notch signaling through interaction with NUMB. It also couples to apoptosis-inducing pathways such as those mediated by the JIP, and it inhibits alpha-AT1 PA's activity. All right, let's see. How about GAB2, GAB2? It's also called GRB2, associated binding protein 2, and it's an adapter protein which acts downstream of several membrane receptors, including cytokine, antigen, hormone, cell, matrix, and growth factor receptors to regulate multiple signaling pathways. It regulates osteoclast differentiation, mediating the TNFR, SF11A, RANK signaling. In allergic response, it plays a role in mast cell activation and degranulation through PI3 kinase and regulation. It also is involved in the regulation of cell proliferation and hematopoiesis, but the GAB2 gene, really, really important. Huge role in functioning properly. Now, KLC1, that one is kinesin, is a microtubule-associated force-producing protein that may play a role in organelle transport. The light chain may function in coupling of cargo to the heavy chain or in the modulation of its ATPase activity. Then PSEM1, that's probable catalytic subunit of the gamma secretase complex and endoprotease complex that catalyzes the intramembrane cleavage of integral membrane proteins such as Notch receptors and APP. It requires the other members of the gamma secretase complex to have a protease activity. It may play a role in intracellular signaling and gene expression or linking chromatin to nuclear membrane. It stimulates cell-cell adhesion through its association with the E-catenin complex. All right. Now, PVRL2 is it's a probable cell adhesion protein. It acts as a receptor for herpes simplex virus, mutant RID1, and herpes simplex virus HHV2, and also the PRV virus, the pseudorabies virus. All right. Now, let's see, which other one can I talk about here short? SORL1, it's likely to be a multifunctional endocytic receptor that may be implicated in the uptake of lipoproteins and of proteases. It binds LDL, the major cholesterol carrying lipoprotein of plasma, and transports it into the cell by endocytosis. It binds the receptor-associated protein. It can play a role in cell-cell interaction. It is involved in APP trafficking to and from the Golgi apparatus. It probably acts as a sorting receptor that protects APP from trafficking to late endosome and from processing to amyloid beta, thereby reducing the burden of amyloidogenic peptide formation. It is also involved in the regulation of smooth muscle cells migration, probably through PLAUR binding and decreased internalization. All right, then the TOMM40, TOM40, that's a channel forming protein essential for the import of protein precursors into the mitochondria. I am so sorry, guys. I'm very sorry. Very sorry, I apologize for that. Now, the WWC is a probable regulator of the HIPPO-SWH signaling pathway, a signaling pathway that plays a pivotal role in tumor suppression by restricting proliferation and promoting apoptosis. Along with NF2, can synergistically induce the phosphorylation of LATS1 and LATS2, and can probably function in the regulation of HIPPO-SWH signaling pathway. It acts as a transcriptional coactivator of ESR1, which plays an essential role in DYNLL1 mediated ESR1 transactivation. It regulates collagen-stimulated activation of the ERK-MAPK cascade. It modulates directional migration of podocytes and acts as a substrate for PRKCZ, and it plays a role in cognition and memory performance.
Okay.
Karen.
Thanks, Sterling. All right, so I think to go through these individually, I don't think we'll do that, only because you've got all the information here in terms of what it does, and it's associated, a lot of these are associated with our Alzheimer's disease. You can see the pathways. A lot of them have direct effect on our amyloid beta plaques, and you can certainly see that the APBB2 here has an association with the precursor proteins for that. So it makes sense that these are going to affect our, and a lot of these will express in the brain, and that's why it has much more of an effect. CR1 is associated separately with gallbladder carcinoma, and I think, and here's our research. You can look up these studies. Actually, notice I haven't got the references on there, so if anyone's really keen for the references, just please send me an email. And we've got various proteins here, PSEN. We actually looked for a lot of research in this one, and we couldn't find research. There's a lot on the PSEN and what it does in terms of how it works, within the nucleus, and how it cleaves the amyloid precursor protein. But as far as finding research on the individual SNPs, there's not a lot there. The PVRL2, that's related to the polio virus, and there you can see some of the Alzheimer's SNPs and what they're associated with. The TOM40, as Sterling said, it's a protein precursor, and most of these are that will then affect Alzheimer's disease and the risk of depression and stroke and things like that. And so these are some of the nutritional strategies that we may use. Herpesine is being used in a lot of cognitive function supplements at the moment. So is acetyl L-carnitine, great at breaking down ammonia. N-acetylcysteine, obviously the brain is very, very susceptible to oxidative stress, so whatever we can do to improve our antioxidant capacity for the brain, turmeric, ginkgo, magnesium, all very important. Green tea, blueberries, really important strategies. Sterling, I think we'll just let's quickly go through these other neurological SNPs, and particularly I think the BDNF is probably the most interesting here. Sterling?
Yeah, it is. I'll take over here now. Hold on. All right, the BDNF, that's the brain-derived neurotrophic factor. It does have growth factor activity. During development, it promotes the survival and differentiation of selected neuronal populations of the peripheral and central nervous systems. It also participates in axonal growth, pathfinding, and in the modulation of dendritic growth and morphology. It is a major regulator of synaptic transmission and plasticity at adult synapses in many regions of the central nervous system. The versatility of BDNF is emphasized by its contribution to a range of adaptive neuronal responses, including long-term potentiation, long-term depression, certain forms of short-term synaptic plasticity, as well as homeostatic regulation of intrinsic neuronal excitability. Now, to be kind of fast on this one, the chat gene, the choline-acetyltransferase, that one catalyzes the reversible synthesis of acetylcholine from acetyl-CoA and choline that cholinergic synapses. Then the CTSD, that one is an acid protease active in intracellular protein breakdown. It is involved in the pathogenesis of several diseases such as breast cancer and possibly Alzheimer's disease. And the last one here, MAPT, it promotes microtubule assembly and stability and might be involved in the establishment and maintenance of neuronal polarity. So, Carolyn?
Yep. Okay, thanks, Sterling. So the BDNF, I guess the key thing there is it really helps regulate our synaptic plasticity. So it's going to be really important for learning and memory. And interestingly, it's actually found in regions of the brain that help control eating, drinking, body weight. And so this gene is going to help with these functions. So I think that's a really important one to consider. And I guess the 6265 gene is the one that's associated with most of the issues in this one. So if you perhaps highlight that, it's 6265, RS6265, which is the BDNF V81M. And it's been associated with increased risk of psychiatric disorders, bipolar, schizophrenia, anxiety, and eating disorders, hence the regulation of the eating function. Chat, the only thing I really want to say there is that it's obviously going to help nerve cells because it's involved in choline acetyltransferase, and it's what obviously facilitates production of acetylcholine. And so if you've got mutations in acetylcholine or choline acetyltransferase, then the production of acetylcholine is going to be reduced. And that's going to have an effect on muscles, perhaps even decreased movement, muscle weakness, myasthenic syndrome, anything like that, that will be as a result of a decrease in the choline acetyltransferase. CTSD affects acetylcholine, and we know that that's a major neurotransmitter and neuromodulator, and it's got very important roles in our central and peripheral nervous system and indeed our autonomic nervous system. MAPT, that's involved with our, did I talk about CTSD? No, I didn't. It's really involved in, this is one of our proteases, and it's found in many cells that are active in our lysosomes, and it's particularly a recycling molecule. So we get issues with brain function, perhaps even muscle rigidity, seizures, respiratory failure, and as Sterling said, often death in infancy if it's a homozygous mutation. MAPT, it provides instructions to make our tau, and that, as you know, it's really important. It's through our central nervous system, and it is also in the neurons in the brain. So it's involved in assembling and stabilizing our microtubules, which are these, good rigid hollow fibers that make up our cell's structural framework. And it helps maintain the shape of them and will also assist in cell division. So when we're thinking this, we should be thinking about perhaps the transportation of materials within cells is not as great. And because it is involved in our tau, it makes sense that this is probably going to be connected with dementia and even Parkinson's disease. Some of the other neurological SNPs, in terms of the research, you can read those. I won't go through that. The first one, though, the BDNF, plays an important role in nicotine addiction. So I think just perhaps look at that SNP when you've got people who find it really difficult to give up smoking. And again, we've got to eat for strength, really. We've got to not eat excess calories. We've got to be watching our omega-3s, things that we've said before. Flavonoid-rich foods are really important. They're certainly going to improve memory and learning. And funnily enough, the regular consumption of blueberries is actually associated with improved thinking, decreased inflammation. It makes sense. Omega-3s, looking at our fatty acids, our relationship between our omega-3s and omega-6s, and eliminating things like our saturated and trans fats. And one interesting factor with the BDNF is that soybeans actually help increase the activity of BDNF. So if you have people with a down regulation, then some good quality organic soybean, may be not milk, but certainly soybeans can help. But it's a fine line, because too much soy will decrease. So soy seems to be a regulator of this gene, whether too high, too low. And they suspect that it's around about 300 milligrams a day that will be derived from phosphatidylserine that improves the cognitive performance in people with that particular gene. And we also just need to watch our supplements, iron, zinc, copper. They're all needed for the body, but if we have excessive amounts, they can damage the brain cells. We also need iron for our oxygen carrying capacity. And so there's a lot of things to consider in this particular. And we've got our cancer and tumour cells. Sterling, I think this is our last section, so perhaps is there one there that you would particularly like to, or would you like to talk about all of them perhaps?
I think we've got one other small section after this, but here I'll post something up on them for you. I know, because we're running short on time. Well, the clusterin gene, CLU, its isoform 1 functions as extracellular chaperone that prevents aggregation of non-native proteins. It prevents stress-induced aggregation of blood plasma proteins and inhibits the formation of amyloid fibrils by APP, APOC2, B2M, CACLA, CSN3, SNCA, and aggregation-prone LYZ variants. It does not require ATP. It maintains partially unfolded proteins in a state appropriate for subsequent refolding by other chaperones such as HSPA8 and HSC70. It promotes proteasomal degradation of the COMMD1 and IKB. These are other genes. It modulates the necrosis factor kappa B transcriptional activity. Its mitochondrial isoforms suppress the BAX-dependent release of cytochrome C into cytoplasm and inhibits apoptosis. It plays a role in the regulation of cell proliferation. The NR112 is a nuclear receptor that binds and is activated by a variety of endogenous and xenobiotic compounds. The TLR4, that one cooperates with the LY96 and CD14 to mediate the innate immune response to bacterial lipopolysaccharides. It also induces the formation of heterodimer of TLR4 and TLR6, which is rapidly internalized and triggers inflammatory response, leading to the necrosis factor kappa B dependent production of other genes like CXCL1, CXCL2, and CCL9 cytokines via MYD88 signaling pathway, and CCL 5 cytokine via TICAM1 signaling pathway, as well as the IL-1B secretion.
Okay, thanks, Sterling. So I think these key ones, when we're talking about cancer, they're really important because they're involved in cell death, tumor progression, and neurodegenerative disorders. So if you can have a look at these pathways. You've got some good links there that you can read about this. The NR1 L2 is that's important because it does affect, and excuse the spelling of bowel there, but it does affect mutations causing inflammatory bowel disease. And it's activated by a range of compounds, including our CYP3A4. Toll-like receptors, they're very important for anyone that knows their immune function biochemistry, because they play a crucial role in pathogen recognition. And so these will affect our cytokines that are necessary for our defense system. And we could probably spend an hour just on the toll-like receptors, but at least you know what this is associated with. And you can see there that the toll-like receptors is involved in digestive issues, rheumatoid arthritis, gastric and other cancers, and periodontal issues. I think, again, diet, lifestyle, limiting red meat, having a more organic diet is important, and we all know cancer prevention strategies, but you know the key genes now that we need to consider when we're talking about this. And we've got here some type 2 diabetes SNPs, and I think this is our last, and we're so sorry for keeping you so long, but there's a lot of information here. But Sterling, let's just go through these key ones.
Yeah, the interferon-induced double-stranded RNA-activated protein kinase is the EIF2AK2. It is IFN-induced RNA-dependent serine 309 protein kinase, which plays a key role in the innate immune response to viral infection, and is also involved in the regulation of signal transduction, apoptosis, cell proliferation, and differentiation. It exerts its antiviral activity on a wide range of DNA and RNA viruses, including hepatitis C, hepatitis B, measles, herpes, simplex virus 1, and it inhibits viral replication via phosphorylation of the alpha subunit eukaryotic initiation factor 2. This phosphorylation impairs the recycling of EIF2S1 between successive rounds of initiation, leading to the inhibition of translation, which eventually results in shutdown of cellular and viral protein synthesis. It also phosphorylates other substrates, including P53, TP53, PPP, 4,5A, and the HHV1 viral protein US11. In addition to serine, threonine protein kinase activity also has tyrosine protein kinase activity and phosphorylates CDK1 and tyrosine 4 upon DNA damage, facilitating its ubiquination and proteasomal degradation. Now, the IDE, insulin-degrading enzyme, that plays a role in cellular breakdown of insulin, IAPP, glucagon, bradykinin, calidin, and other peptides, and thereby plays a role in intracellular peptide signaling. It degrades amyloid formed by APP and IAPP. It may also play a role in the degradation and clearance of naturally secreted amyloid beta protein by neurons and microglia. The membrane-associated isoform acts as an entry receptor for varicella zoster virus. Now, the IL-6, interleukin-6, this is a cytokine with a wide variety of biological functions. It is a potent inducer of the acute phase response. It plays an essential role in the final differentiation of B cells into Ig secreting cells involved in lymphocyte and monocyte differentiation. It acts on B cells, T cells, hepatocytes, hematopoietic progenitor cells, and cells of the central nervous system. It's required for the generation of T17 cells, also acts as a myokine, and it is discharged into the bloodstream after muscle contraction and acts to increase the breakdown of fats and to improve the insulin resistance. It also induces myeloma and plasmacytoma growth and induces nerve cell differentiation.
Okay.
I'm done.
Thank you. Okay, so these couple of SNPs we'll talk about. They're obviously associated with inflammation, IDEs, affects insulin breakdown, have been associated with Alzheimer's disease and type 2 diabetes. And our interleukin-6, we've probably all done a lot of research about interleukin-6, but they're both a pro-inflammatory cytokine and an anti-inflammatory myokine, and it's secreted by T cells and macrophages, and it will obviously help with our immune response, particularly during infection, after trauma or burns or something like this. And it's key in playing a role in fighting infection. So we'll probably go into this in a lot more when we get into immune function, so we won't talk about that too much today. So, and there's the research, and we're certainly sorry to keep you for so long. If you do have any questions, send them through to us now, or you can send them through to the info at MTHFR support. Thank you so much for joining us today. And Sterling, is there anything else you'd like to add? This is a big category, and sorry for so many slides.
Feedback on your end, Carolyn. Horrible.
Sorry?
We're getting god-awful feedback on your end. Thank you.
Okay, thanks. Are there any questions? Anyone got any questions for this section?
Okay, Carolyn, we don't actually have any questions that have come through,
right?
Other than about the presentation slides, which we're going to email to you, so you will actually get those, so you can look at the research yourselves. And I'd just like to say that that's completed your webinar on the yeast, alcohol, and Alzheimer's today. If you do have any questions, just email them through anyway. And the next part of the learning series, number 4, is on the 20th of October at 7:30 for the US and 21st of October at 11:30 for Australia. And we'll be covering methylation and methionine. So I'd just like to say thank you, Sterling, founder of MTHFRsupport.com, and thank you, Carolyn, again for such a great presentation. So if there aren't any questions, which there aren't, there's nothing coming through, Carolyn.
Okay.
So perhaps we can sign off, and thanks everyone for attending.
Thank you.